Thank you all for joining us today. I'm super excited to be joined by Dr. Eric Singhi. We both work at MD Anderson. He is in the Thoracic department. I'm in the Breast Medical Oncology department, and we're so excited to have this crosstalk today about the use of those drugs, antibody-drug conjugate that we started using in both cancers. And today we're going to take a deeper dive on how are they used and learn from each other. Dr. Eric Singhi, how are you doing? And thank you for joining us.
I'm doing well. Thank you so much for having me. Excited to be here. More importantly, excited to learn from you. You guys are always teaching us in lung cancer how to improve outcomes for our patients. So
I would like to say the same. I would like to say that we also got taught a lot when it comes to the field of immunotherapy from you guys. So it's amazing to see. But finally, we have some agents that cross those boundaries.
Yes.
And we're using them both in our own specialties, which is really exciting to see and learn from each other. So today's session is just to talk about those drugs that we use in common and talk about them and see how is it different between how it's used in breast and how it's used in lung. So first, let's talk about the landscape.
Yeah.
So I'm going to tell you for us in breast, we were pioneers in the field of antibody-drug conjugates.
Yep.
We started using them in 2013 with the first ADC that came to breast, and this is trastuzumab emtansine, TDM1. We like to call it TDM1. And that drug really revolutionized the field for us. For the longest time, it was the poster child of our field.
Yeah.
And I'm going to be honest here. It was the drug that made me fall in love with breast oncology.
Wow, okay.
Yeah, because it was something like science fiction, right? Yeah. You're thinking about this drug that can go and target the cancer cell and spare the healthy cell and deliver a payload that will kill that cancer but spare healthy. Yeah. It was like the silver bullet that we keep hearing about, that you can spare the host but target the cancer. So this was something like fantasy.
Yep.
I still remember the first depiction that was in that paper talking about that drug, and I was like, oh my God, this is where I want to be. Sign me up.
Oh, I love that. Yeah.
And it was crazy. And that was the only ADC we had for almost a decade until we had the emergence of trastuzumab Deruxtecan, and then we had sacituzumab govitecan, and now more recently we have Datopotamab Deruxtecan. Let's go into a deeper dive about, can you lay the field for us? Where does ADCs fit into the thoracic landscape at this point in time?
Yes, that's a great question. As of 2026, we are reserving ADCs as standard of care, right? Not clinical trials, but as a standard of care after patients have disease progression on oral targeted therapies if they qualify, after chemotherapy, after immunotherapy. So it's reserved for those later lines.
Okay. Is there a specific patient? Because I know, like, for example, EGFR mutations are something you guys look for. Also, there is MET alterations and others. Are there specific population you look for, or for all comers?
Yes, this is a good question. This definition of biomarkers is really exciting because we have defined biomarkers, and then we have emerging biomarkers, and we have newly emerged biomarkers. So one of the sort of recently emerged biomarkers is CMET, which is tested through IHC, protein overexpression. And so you can match patients if they qualify with an antibody-drug conjugate like telisotuzumab vedotin. That's an option. You also have to be looking for IHC testing to define HER2 alterations, and that can be defined by protein overexpression as well. And so if you're HER2 positive, IHC3+, that may open up the door for an ADC like trastuzumab Deruxtecan, right? And then we also have ADCs where you don't necessarily have to have a particular biomarker to qualify. Yes, they may have to have disease progression if they have EGFR-directed therapy, but after that, the door is a little bit open in terms of being able to use another antibody-drug conjugate like Dato-DXd.
Yeah, no, that's pretty exciting. And in breast, we have a similar thing. So some of the antibody-drug conjugate that we use need a biomarker, like for example, trastuzumab Deruxtecan. Same thing, we need to have either an overexpression. So these are the HER2 positive breast cancers that automatically qualify. But now they expanded the label. We have this HER2 low and ultra low.
Yes.
So I'm really wondering if that's going to eventually also translate into other cancers.
I'm sure it will. All this nomenclature is so confusing. I can't tell you the number of times we both work with trainees at our institution. We also do a lot of teaching and education in the community. And the nomenclature of all these biomarkers is so confusing. HER2 altered means multiple things. So in non-small cell lung cancer, I'm curious what it means in breast cancer. But HER2 alterations, you can have protein overexpression, you can have amplification, you can have the mutation. So there's a lot of different things. And same with CMET, right? You can have the same type of confusion. So
yeah, no, for sure. So for us, there is the HER2 positive breast cancer, which have their own. But then there is the hormone positive, which is the most common subtype of breast cancers. So those initially, we treat them with endocrine therapies, plus minus targeted therapies.
Okay.
But eventually, all of those will become endocrine refractory. And once they're endocrine refractory, usually the treatment was chemotherapy.
Right.
Sequential chemotherapies, which don't work that well.
Yep.
Let's be honest. We're
Yep.
just giving something just because we want to give something, not give up, because patients a lot of time are not ready yet.
Yeah.
But we all know that the prognosis becomes very grim. But now that we have those ADCs, it's very exciting.
Yeah.
We're seeing that it's really revolutionizing the field for us. So yes, so those come for those hormone positive, endocrine refractory, and also our triple negative.
Okay.
The triple negative was the worst of the worst. Think about your terminal lung cancer patients,
Yep.
to be honest.
Yep.
The runway was very short for those patients. Usually your fight is in the first line therapy. After that, about 50% of the patient drop off. Attrition rate are 50% after first line. And usually we don't have very good options for them to rescue them. But now with the emergence of ADCs and getting more options, we're getting a lot of exciting options for those patients. So that goes to one of the most exciting drugs for me at this point in time.
Wow.
Let me tell you, forever I thought that nothing is gonna move trastuzumab deruxtecan from its number one winner all. And I always tell my fellows, I joke with them, I'm like, if you're doing an exam,
Yeah.
and any of the answer choices is trastuzumab deruxtecan, don't even read the question. Answer it
Just
and
choose
move on. It's going to be probably right.
For us, those are our oral targeted therapies as of now. Yes.
So for me, I used to always tell them, use T-DXd and move on. Don't
Yep.
even read that question. But now, you know, with the experience I've been having with Dato-DXd, Datopotamab deruxtecan, I am really surprised. Number one, about the efficacy of the drug. Number two, about how well tolerated it is. It's truly have been amazing to have in my tool shed.
Yeah.
I love having that drug. So first, before talking about the studies in breast, can you tell us about what is the study that brought Datopotamab deruxtecan, or Dato-DXd for short, to the lung field?
Yeah, absolutely. So we recently got FDA approval for this drug last year, and it was based on data that came from the TROPION-Lung01 and TROPION-Lung05 studies. This was a pooled analysis. These patients in particular had EGFR positive disease. That's really what this indication is for. So patients had EGFR positive disease. They had to have had disease progression on EGFR directed therapy. So that's pretty broad, because we'll talk a little bit about how in the frontline setting now for patients with a classical EGFR mutations, we have options, and
Yes.
it's nice to be able to have options.
Always.
What do I mean by options? Combination therapy, single agent osimertinib, right? So we have options. So if a patient does experience disease progression on EGFR directed therapy, subsequently experiences disease progression on platinum-based chemotherapy, that's where the door opens for Dato-DXd.
Okay.
And so it's a nice option because based on what we choose in the frontline setting, we have this very convenient option of an ADC to introduce. You don't necessarily need an additional biomarker to be able to pull it. And objective response rates are around 45%.
Okay.
Median duration of response about 6.5 months. So it's nice to be able to see that.
Yeah, no, definitely. For us in breast, Dato-DXd first came from the also a tropion study.
Yeah.
So it's a tropion breast 01, which was in the hormone positive subgroup of patients that are metastatic and that are endocrine refractory.
Okay.
And usually the study allowed 1 to 2 prior lines of chemotherapy when they become endocrine refractory. And it compared Dato-DXd to investigator choice chemotherapy. And the main comparator was a drug called eribulin. Anytime you get to eribulin, for me, is a Hail Mary.
I remember that as a trainee. So I will say, yeah, the last time I saw a breast cancer patient was years ago, but I remember that.
Eribulin is always the Hail Mary drug.
Yeah.
You know, that's the last thing you're going to do when you're losing. You want to throw this like a 60-yarder. That's when you use eribulin. So the main comparator, 60% of the comparator was eribulin.
Okay.
Now, this drug really improved outcomes. You can see that it improved the median progression-free survival. It increased it close to 7 months. But what's really exciting when you look at it, if you look at the hazard ratio, for me, the hazard ratio really, I use them a lot. And I like to hear your opinion about that. Because for me, a lot of patients tell me, okay, how much better this drug is going to be compared to the alternative.
Right.
And that's for me the hazard ratio. Because the hazard ratio is around 0.6. So meaning patients do 40% better or less event of like death or progression when you use Dato-DXd compared to the standard of care, which is eribulin. And the patient love that. Like when they hear that, like, okay, definitely this is the drug I want. And that's what the study showed. But what's also exciting when you look at the response rate, it doubled.
Wow.
Like if you look at the response rate compared to chemotherapy versus the response rate you see with Dato-DXd, it doubled. It neared 50% response rate with that agent. And at a time where we don't expect responses anymore.
Yeah.
What I'm expecting is stability of disease. Yet you are seeing almost half the patient, you see responses in those patients, which is really exciting to see. Have you seen something similar? What was the comparator
Yeah,
on the study?
absolutely. So it was the Tropion-Lung01 study, and they looked at docetaxel. Docetaxel, I guess, is our eribulin, if you will, right, in lung cancer. And nobody likes giving docetaxel. Nobody likes it. You the side effects, the toxicity, and the response rates, 10, maybe 15%, right? And so I told you objective response rates now with Dato-DXd in this setting, we're looking at almost close to 45%. Not only that, but we get a duration of response of, almost a median of 6.5 months. And so it's really nice to be able to have this option. Anything that beats docetaxel, I'm going to take it,
For sure. So this was the first indication we got in breast. The second indication that we don't have yet, but it's coming, is in the triple negative breast cancer. But they presented the data at ESMO Congress, which was really exciting to see. And that's in the triple negative patients. And these are the patients that truly need options. And here they're using it as first line in patients who do not qualify for immunotherapy.
Okay.
And this is the Tropion Breast 02. And that study here was also compared to investigational choice chemotherapy. Over here, the choices are more broad. Some people like to use, but single agents, either like Abraxane or something like paclitaxel. Even docetaxel was one of the options on that one. So here also they showed like meaningful improvement of progression-free survival. And there is a trend toward overall survival improvement, which is really exciting to see. Also, you see very important improvement of response rates, durations of response, and all those. Now, when you go to lung, is there another subgroup of patient other than the EGFR positive patient that qualifies for Dato-DXd?
So in those Tropion lung studies, the Tropion-Lung01, Tropion-Lung05 study, they did include other patients with other actual genomic alterations. It was really that signal in EGFR where we saw a nice response, and that's where we've really honed in. That being said, I'm really excited about the clinical trials that are continuing to enroll in this space. We're looking at combination therapies, right? ADC plus even oral targeted therapy, and trying to move these things even into the front line, like you were saying. So more to come, but as of today, really restricted to EGFR disease and reserving it after EGFR-directed therapy and platinum-based chemo.
So let me ask you this. Let's talk about sequencing a little bit. So immunotherapy obviously has a huge role in lung cancer.
Absolutely.
Where does ADC fit? Do you give it before an immunotherapy plus minus chemotherapy, or double it, like dual ICI inhibitors? Or do you do it after? Where does it fit?
Yeah, I think this is a good question. As of today, we're reserving ADCs for after chemotherapy, after immunotherapy. What's going to happen in the future? I think it's going to be a really exciting question. Even in small cell lung cancer, we're starting to think about, are we going to go away with that platinum-based backbone? Are we going to start to use ADCs? It's a really exciting time and a privilege, honestly, to be a thoracic oncologist, to be a breast cancer oncologist as well, too, right? Because we're trying to move these more targeted therapies earlier and earlier to meaningfully change outcomes for our patients and hopefully give them more time with their families and their loved ones.
For sure. Are there studies looking at the immunotherapy plus ADCs in lung?
Yeah. So, one of the things we have to watch for, and we're probably going to talk about this, is toxicities, right? Toxicities add up. One of the ones that we're really worried about as a thoracic oncologist, I'm sure as a breast oncologist too, is ILD or pneumonitis, right? So we have to be very careful with that. Same with our targeted therapies too. Some of our targeted therapies can also cause pneumonitis, ILD. So I think that's sort of something that we're watching in terms of these combination strategies, but I'm excited for the potential of it.
Yeah. So for sure. So for us, we have studies looking at the combination. We have especially the European are more most adventurous than us in the US, I feel. So they already start using those drugs in combination with immunotherapies, mainly Durvalumab, because it's under the same hood, right, of the company that make Dato-DXd. And the results have been astonishing. I'm really surprised how well they are. And that speaks to a little bit the mechanism of action. At the end of the day, this is an antibody as well. Yes, we like to say, like we said earlier, it's like a heat-seeking missile, right?
Yes, that targeted missile.
Yes, the targeted missile. But that targeted missile is an antibody.
Yes.
And antibodies are highly immunogenic. Right? So they will lead to this immune cascade happening at the tumor microenvironment level, which will recruit the immune system. So it's right there. So if you can unleash hell by adding an immunotherapy, we're all for it. And the data, the preliminary data we're getting from the Begonia study, from also the iSPY study, these are platforms that look at multiple different arms. It's very, very encouraging about using it together. Is there something similar happening along?
Yeah, we're still trying to think about ADCs, exactly like you said, to almost salvage therapy, right? After patients have this really nice response on immunotherapy or after their targeted therapy. We treat these patients for sometimes even years, right? So we're really turning, I know breast cancer is almost like this chronic disease, but we are really turning lung cancer into a chronic disease as well.
It seems like it,
and it's because we're giving durable responses to patients. And so I think quality of life in addition to efficacy, is so important, which I want to talk to you about at some point here with all of these drugs. How do we maintain quality of life? How do we make sure that patients are truly being able to tolerate the treatment we're prescribing?
No, I really want to talk into this, but I'm really interested in knowing, can you combine ADCs with targeted therapies, like with osimertinib, for example?
So that's a question that's being asked. Yes, so osimertinib plus Dato-DXd is an example, right? That is something that is currently being evaluated to figure out, one, is it tolerable? And second, can we get an efficacious response that's meaningful to patients? I'm excited about it, right? If you think about the mechanism of action, you very nicely described ADCs. EGFR-driven disease tends to remain EGFR-driven, and so do you keep that backbone, right? We've asked that question. There was a recent Compel study that came out at the World Conference of Lung Cancer. And essentially, it was prospectively asking the question, if a patient experiences disease progression on oral targeted therapy, osimertinib, at second line, do you keep that OC backbone going, but add in platinum chemo, or do you drop it and just stay with chemo? This was a practice reinforcing study, in my opinion. It showed us TLDR, right? That yes, it's meaningful. Yes, you're going to see CNS disease protection if you keep the OC backbone going. And so logically, it makes sense to me that these combination strategies will be the answer.
No, it makes perfect sense. We do the same in breast, when we target the estrogen receptor pathway. We tend to keep on going, even though patients are progressing on multiple lines, but we keep targeting that plus adding other stuff to it.
Right.
So it makes perfect sense to keep doing it, because I truly feel cancers are very heterogeneous.
Yes, absolutely.
Right? They have multiple clones.
Absolutely.
So sometimes a clone emerges maybe that's not responding to osimertinib, but there is the other clone that's responding to it is still there.
Right.
But you've been put in under check by that drug. Now, if you're going to stop the drug and go to something else, it's not under check and it can start growing again.
Absolutely.
So it makes so much sense doing both.
Let me ask you a question. So in lung cancer at time of progression, if a patient is on EGFR-directed therapy and then we start to see disease progression, if we can get a biopsy, I'm pushing for it because I want to repeat tissue profiling. I want to understand the reason for acquired mechanism of resistance. Can I target it? Can I not? Do you guys do that in breast cancer?
Yeah.
Okay.
No,
Teach me.
This is very important for us. So at every progression, what we recommend at a minimum, a liquid biopsy.
Yeah.
So you can check for emergent mutation of resistance that you can target. But if you can get a tissue biopsy, it's always the holy grail.
Absolutely.
Right? Because then you can do all the immunohistochemistry stains that you cannot do at this point in time via liquid biopsy. So you cannot get insight on the receptor status for us, for example, by doing a liquid biopsy. Is liquid biopsy something you guys are doing, or you also like more tissue?
Yeah, I mean, so tissue is our gold standard, but you're right. Liquid biopsies at any time of progression, I'm often ordering that, but you can't always trust it, right? It depends on tumor shedding levels. You can't get IHC testing, and importantly, with a liquid biopsy, you can't check for histology transformation. So small cell transformation can happen in up to 10% of cases.
Oh, wow.
If patients have EGFR-directed disease, EGFR-mutated disease, they have non-small cell lung cancer, you need to be looking for histology transformation. So.
This is amazing because also it's 10 to 15% of hormone positive that can turn into triple negative.
Okay, so we have a lot more commonalities than I thought. I didn't realize.
We do. It's fascinating, right?
Yeah.
So that's another thing why you want to check the receptor status, because you want to see if they convert it to triple negative, which is fascinating.
Wow, okay. See, I'm learning so much from you.
Yeah, me too. 10 to 15%, which is fascinating. All right, so let's go back to Dato-DXd and let's talk about those side effects, right? Because a lot of people worry about them. Now, I'm here to tell everybody, truly, we make it bigger than what it seems.
Yeah.
Let's start with one that is pertinent to both, but more to lung, because that's the area you're targeting the most, and that's ILD.
Yes.
What can you tell us about the rate of ILD that was seen with the Dato-DXd and how to manage it? How to do it?
Yeah, so this is a really important one. ILD pneumonitis, I'm constantly thinking about. What I want to also emphasize is that ILD pneumonitis from ADCs is very different than immune checkpoint blockade, and maybe we can get into that a little bit. The rates that I have for you from the tropion studies, from these pooled studies, is about 7% ILD. So not super high, but still something we need to be watching for, still something we need to be vigilant about. Thankfully, grade 3 or higher, pretty low, almost like less than 1% if I remember correctly. So I feel better about that, but it's definitely on my radar. And even for grade 1 pneumonitis with an ADC, with a drug like Dato-DXd, I'm even pausing the drug. I'm thinking about what to do for my patients, and I'm watching them very closely.
Amazing. So, and let's put it in perspective here, because now I'm going to tell you the numbers I have in breast.
Okay.
But when you give a drug like trastuzumab deruxtecan, what is the ILD rate that you see in lung cancer.
Yeah, so it can be higher. So it really depends on our dosing. And I'm trying to remember what the breast cancer dosing is for you guys, but we use a lower dose because we saw higher rates of ILD pneumonitis, right? Okay. So it was upwards of 15%, if I remember correctly, if you use the higher dose, dropped significantly if you use the lower dose. And so I would say it's roughly about the same in terms of ILD, maybe even a little bit less.
So you guys
with
use
Deruxtecan. So we use 5.4.
5.4.
What do you guys
use? We
use?
use 5.4.
Okay, yeah.
Yeah, for the same reason, because the earlier studies showed that the higher dose caused ILD. So for us with the Dato-DXd, we see half of what you guys see.
Wow.
So it's almost about 3.5% ILD risk. And you're right, we don't see much of those grade 3 or higher. They're maybe less than 1% in those patients. But definitely it's much lower than what you see with the trastuzumab deruxtecan. Over here, across every single study, you see somewhere between 10 to 12%.
Yeah.
So it's like a third of that we see with the Dato-DXd, and half of what you guys see in lung, which is really reassuring. Now, you're right. The way we see it, and for us, that was the first drug that caused ILD, to be honest. Not Dato-DXd, but T-DXd was the first one. So for us, it was a learning curve. I assume with you guys, you've been dealing with this for a while. How is it different when you look at ADCs-induced ILD versus immunotherapy-induced ILD or TKI-induced ILD?
Yeah, I mean, I think first, you can see the ILD happen sooner on ADCs than you do with immune checkpoint blockade. So I think being more vigilant even at the beginning is more important. Second, it can take longer to manage, I feel, to be honest with you. And you want to catch it quicker. Otherwise, the domino effect happens a lot sooner than it does with immune checkpoint blockade. Third, usually if I have a patient with immune checkpoint blockade and they have pneumonitis or there's concern, it's grade 1, restricted just to the imaging, the patient's otherwise doing well, we usually push on. We feel okay, we feel comfortable. I don't feel that way with ADCs. We hold the drug, we don't do it. Grade 2 is a hard stop. If you get grade 2 pneumonitis with an ADC, we don't re-challenge.
Yeah.
And I think grade 2, actually there's the spectrum of grade 2, and I'm 100%. Sure you can appreciate that, right?
100%.
And so I'm always asking our expert interventional pulmonologists and our pulmonologists at our institution, hey, help me with this patient. Where on the grade 2 spectrum are they for immune checkpoint blockade? Could I one day re-challenge them? Yeah. I'm a lot more nervous to do that with an ADC.
Yeah, and there was, for us in breast, there was a provocative paper by Dr. Hope Rugo. Because grade 2, you're right, if you follow, because there's black box warning on those drugs with the ILD. And it's a hard stop if you get grade 2. So any grade 2, what we mean is any symptomatic ILD that's considered a grade 2. Grade 1 is when you catch it on a scan when it's asymptomatic. But for us, if you follow the guidelines, they say any grade 2 or above, you stop. However, there was this provocative paper by Dr. Hope Rugo that looked at those grade 2s. And you're right, grade 2s do not all come in single flavor. So those grade 2s of patient that they held the drug, treated with steroids, patient did better right away and went back to essentially a grade 0, those patients were re-challenged, although the guidelines say do not re-challenge.
Yeah.
But on that small observational study, they re-challenged and they did fantastically well.
See, I love studies like this. This is what we need. We need to encourage to have these studies, right? Because in the real world, we're going to run into these circumstances and we need to know what to do and 100%. We need to have some comfort. So I love that.
100%. It shouldn't be black and white. It should be more of a spectrum. Because I agree. I feel comfortable if patient completely resolves.
Yeah.
Because those drugs are very important.
Yes.
We don't have something else coming after that can salvage them.
Yes. Right? Yet. But as of now, you're right. I mean, we need to be able to safely give these drugs and keep patients on therapy and give them that meaningful extension of their lives and the quality of life. I think both are important.
Yeah, no, for sure. Another side effect that people worry about a lot with Dato-DXd is the stomatitis. So in our studies, it was close to 60%.
It's about the same for us, about 60-ish%.
Yes. Yeah. So, but for us, the thing about stomatitis, we had to deal with it with another drug that we've been using for a decade called everolimus.
Yes.
So with everolimus, we learned a lot. So first, we started telling patient, make sure when you take the pill, take it with food. I had some patient back then, before we started doing the steroid mouthwash, they used to do, like the sushi roll, the rice. They used to put the pill in a ball of rice and take it so it doesn't touch the mucosa and doesn't touch. And that helped a lot. And we used to do that for a long time until we got the study called the switch study.
Yeah.
So that was for oral dexamethasone. It was switch and expel 4 times a day, and that changed everything. Everolimus became so easy to give.
Yeah.
And so then when we started using Dato, now on the studies, they did not require a steroid mouthwash. So that's why you see the 60%. So we were all afraid we're going to see that. But let me tell you, we're very well accustomed to using steroid mouthwash. So when we told our patient, just do it like we tell them the same regimen you do with the everolimus, it's a non-issue. Truly, it's non-existent. I've been using it now for a year because it got FDA approved for us a year ago.
Okay.
So I've been using it for a little bit over a year now. And honestly, it's not an issue in practicality.
Yeah.
How about you guys?
Yeah, I mean, we're very vigilant about this. So, you know how there's like head, shoulders, knees, and toes. We've talked about lungs. We've talked about mouth. We're going to talk about eyes. So I very much focus on that with counseling. So the mouth, you know, obviously oral hygiene and care is super important. Obviously thinking about using the dexamethasone mouthwash, not even thinking, but doing it multiple times a day. That's inherent. That's ingrained whenever I'm counseling patients, whenever they're getting ready to start, it has to happen. So the other big thing too is cryotherapy during the infusion, right? So grab your popsicle, chew your ice, whatever you got to do. Keep it cold throughout the infusion.
No, that is amazing. Yeah, we tell them to chew on ice,
Yes,
right?
yes.
When they're sitting there, which is fascinating to see. But I also always tell them that steroid mouthwash is a preventative treatment.
Yeah.
All right. It's not gonna treat
Right.
once the mucositis happens. So
Right.
so that's why when I counsel our patient, I'll be like, listen, these are preventative treatments. So don't wait until the mucositis happen
Right.
and then start doing the mouthwash, because it's not gonna help at that point.
Yeah.
It prevents it. It will not treat it.
Yeah.
Is that something similar you guys do?
Yeah, absolutely. It's all about preventative care. And I like how you said, you know, when they did the studies, it wasn't mandated, but now we're learning.
Yes.
And so we're going to get updates about what is the real world, you know, experience. Once people are using dexamethasone, once people are counseling very significantly about using oral hygiene and making sure that patients are aware. I'm curious though, how do you treat it if it does develop and they've tried using the dexamethasone mouthwash to prevent it?
So I learned something new
Okay,
from
teach me.
our
Yeah.
colleagues
Yeah.
from ENT. They have something called Helios.
Yes. Yep.
This is fantastic.
Yeah.
This works so well.
Yeah.
So Helios is basically a powder that comes, it has like a few of the amino acids and other stuff that are really important and vital for the epithelial cells of the mucosa. So basically they drink it twice a day.
Yeah.
Before I learned about Helios, mucositis was frustrating because it takes a while to heal.
Yep.
And and if you keep treating them, it's not going to get better. So you have to hold treatment until it heals fully, so you can start, because it affects their well-being, right? Like they need to eat at the end of the day. We need to eat, right? There's no way around it. We need to eat to stay alive. So basically, like you had to support them. We used to give magic mouthwash, right? Just a magic mouthwash, just coats them, makes it more bearable to eat. But this Helios is fantastic. Nowadays, when they get the mucositis, within a few days, it's resolving.
Yeah.
Which is something, like when I learned about it, I was like, are you kidding me?
You should have called me earlier. I also treat some patients with head and neck cancer, so I know about Helios. Yep. My other trick up the sleeve is the baking soda, salt, lukewarm water. That rinse works really well to kind of help patients. So I've got you if you need help.
Yeah. We should have done this earlier.
Crosstalk, yeah.
The Helios is fantastic.
Yes.
I mean, I swear, I use it so much right now. I love it.
Yeah.
Yeah. Now, another side effect that for us was very initially alarming, but now that I have used it for a year, I can tell you I'm very comfortable with it, and I'm going to call it like it is the dry eyes.
Yeah.
I know they like to call it ocular toxicity. And
Yes.
when you hear that word, ocular toxicity, you're like, oh my God, what's happening? Do I really need to send those patients to ophthalmologists? Do I really need to send them to optometrists? And initially I was like, listen, I'm not going to start until you go do that checklist, bring it to me, I have it in your chart. It's a liability issue. Right now, I'm so much more laid back. It's dry eyes.
Yeah.
I don't even send them for ophthalmology or optometry. I do not do that. I just tell them, you know what, do your lubricating eye drops. That's about it. And even patient will give you some feedback. And I tell you, the problem truly is when they sleep at night, in the morning, they feel their eyes are sandy. So they feel like if they do those lubricating eye drop right before they go to bed, this is the best time. They wake up in the morning, they don't feel this sandiness in their eyes, and they're doing great. So for me, I feel like this is a giant made out of paper that they made it feel like they called it ocular toxicity, scared everybody.
Right.
How did it translate for you guys?
You're right. I mean, I'm still adopting to this drug, so I do still send my patients to go see an optometrist or an ophthalmologist. I do recommend, I like to have that baseline, but you're right. I mean, really the experience I've had is the dry eye. And so artificial tears, the lubricating tears are really important. Patients know they need to stock up on that. In addition to all the oral care things that we talked about, their tongue scraper, their floss, you name it, right? So they've got this whole little care package, if you will, ready to get started. But I am starting to feel more comfortable with all these toxicities. And importantly, we have to educate ourselves. We can't be afraid to not reach for this drug, right? We have to be able to reach for it because it is meaningfully providing responses for patients.
And I truly think in a year's time, you're not going to even send them to
Yeah.
us.
Let's have another conversation in a year. Yeah.
Because I was the same initially. I was really freaking out initially. Now I'm like, okay, this is a piece of cake, guys. But the one thing I note, it's very important to counsel our patient about is not to use contact lenses.
Yes, that's really important.
Yeah, that's very important because contact lenses, then you can see damage to the
Absolutely.
cornea.
Yeah.
And that's something that I really counsel them a lot about.
Okay.
And you know, some patients, and this is one patient I had, she was like, then I'm not going to do it.
Huh.
And I was like, that's okay. Because like you said, our patient, for them, it's also important how they feel.
Absolutely.
Because we're not curing our patient, those patients at this point in time. Hopefully in the future we can.
Right.
But quality of life is so important. And that patient was like, for me, if I go back wearing glasses, I'm going to be depressed.
Yeah.
That's what's going to make me depressed, not my cancer.
Yeah.
So that's why it's important to talk about the contact eye lenses, because for me, it's an absolute no-no. That's one of the things that I cannot be like, okay, it's okay, you can use contact lenses, because then they can really damage their cornea.
Right. Yeah. I mean, I think what you're hinting on is the importance of shared and informed decision-making, right? We always make these assumptions about patients like, oh, it's all about the response rates and it's all about the efficacy. No, it's also about the quality of life. And I think when you counsel patients appropriately, they understand what they're signing up for, how to prevent some of these toxicities, how to manage some of these toxicities. They can really make that informed decision. So I applaud you for asking. I think that's really important.
Yeah. One last thing that we see with those ADCs is the nausea.
Mm-hmm.
How are you guys managing the nausea because of ADCs, especially with Dato-DXd?
Yeah, I mean, I think we're getting really good at nausea management. We have so many tricks up our sleeves now, right? We have so many different classes of drugs, and I'm not afraid to reach for them. So obviously, we've got our standard pack of antiemetics that we have before the infusion. What I like is it really doesn't change the workflow much in terms of giving Dato-DXd. It's every 3-week dosing for us. Our competitor is docetaxel, right? Which nobody wants to go to with the toxicity, with the very low to modest response rates. But it still has the same schedule of every 3 weeks, which is really nice. And so I don't think it disrupts the schedule very much, which is nice. What do you do?
Yeah, so something I really like with the Dato-DXd and T-DXd is the low dose olanzapine.
Okay, yeah. It's my favorite. It's my magic bullet. I love olanzapine.
A game changer.
Yeah.
Like 2.5 milligram, you take it once a day at night.
Nighttime.
For me, it has 4 winners. The first winner is the patient, right? You're controlling their nausea, they're feeling great. But also it makes them help them sleep. So when they take it at night before they go to bed, within the first half an hour, they feel sleepy and they have the best sleep ever. Third, it stabilizes their mood because olanzapine is an antipsychotic medication at the high dose.
And you need to warn patients about that, right?
100%.
Because the first thing they're going to do is Google olanzapine, and then it's going to say this is a medicine for psychiatry. And you're like, wait a second, you didn't tell me. Yes.
So the third one is they feel good.
Yep.
Their mood is good. Their mood is stable. And the fourth one is us as doctors,
Yeah.
because patients are not complaining about that drug.
It's true.
They're not sending my short messages.
It's the magic bullet,
It's the
right?
magic bullet.
Yeah, I agree.
So I love olanzapine.
Yeah.
It's truly a game changer when you give it with Dato-DXd and when you give it for T-DXd.
Yeah.
It's my magic drug. I give it to all patients when they go on that drug. And I'm glad that you guys also use it.
I am not afraid to reach for olanzapine. I love it.
Me too. It's such a small dose. Sometimes I even do half a tablet, 2.5.
2.5.
Lower. Sometimes I even tell them you can take half of that dose if they're worried.
Wow,
And
yeah.
it still works well for the nausea.
Yeah.
All right, so now we want to shift gear a little bit and talk about T-DXd. So for us, T-DXd truly at this point in time is a poster child of breast oncology. You can use it in every single subtype of breast.
Wow.
And it's so funny about that because I came into an era, we're both started at the same time, practicing. And we came into an era when we were still in our fellowship. This is the precision oncology.
Yeah.
We're going to get into a space where we're going to treat different patients based on the cancer specific alteration and stuff like that. And then T-DXd came, and I feel like I'm Oprah in the clinic. You get T-DXd, you get T-DXd, everybody got T-DXd, right? So I feel like now we got into an era, you have this drug, it's like you're going back, you're tracing back, where everybody qualify for a T-DXd. And that speaks to how good and how meaningful that drug improved outcomes. Now, for us, right now, we can use it initially only in HER2 positive disease, but now we had an expansion of the label where we can use it in patients that are HER2 low, meaning IHC 1+, 2+, FISH negative.
Okay.
But recently, we can even use it in the ultra low.
Wow.
Any speckle of staining.
Wow.
Any speckle.
Yeah.
Even less than 1%.
Yeah.
But you see it, they can qualify. Which is amazing. It really expanded the label. Now, then we got also the pan-tumor indication for HER2 mutation, which was fantastic. Because now if you have a HER2 mutation that you're picking up, you can give it right away. How are you guys using it, and what's the efficacy you guys are seeing?
Yeah, so the nomenclature again with ERB2, HER2 in non-small cell lung cancer is very confusing. So when we say HER2 altered disease, it can mean a few things. You can have the HER2 mutation, happens about 2 to 4% of cases, and you could qualify in the second line setting right now for T-DXd. But we also have oral targeted therapies now, even one that is approved in the front line for HER2 mutation, specifically tyrosine kinase domain activating mutation. So that's HER2 mutated. Then you can have HER2 with protein overexpression, which we define as IHC 3+. We're not ultra low yet. We're not even low. We are 3+. So, yep, and that's reserved after
it's
patients
coming.
have disease. Yeah, it's coming, I'm sure. When we do this crosstalk in a couple of years, I'm sure we'll be talking about this. We're always taking a page out of your book, right? So yeah, we do reserve that if patients, have exhausted other options and we have that available. So that's kind of when we're thinking about using T-DXd. But there are studies going on right now where we're thinking about moving T-DXd into the frontline setting for HER2 mutated disease.
Okay.
Yep.
Now help me understand. Is it also like Dato-DXd only for EGFR positive tumors, or is it for all comers?
No, it's for all comers. So one of the things that we're going back now and looking at is getting archival tissue, right? To say, okay, we need to get IHC testing. I tell people actually that we were so focused on NGS for a while with lung cancer because I tell patients this, and this is where the light bulb goes off. I say, I don't treat lung cancer, I treat your lung cancer. And the way that I do is by understanding the biology of your lung cancer. And so we were so focused for a while on NGS testing, DNA, RNA, DNA, RNA. And then it's like IHC made this sexy comeback in lung cancer, right? Where we were doing just PD-L1, but it's like, hold up, now let's check HER2, let's check CMET, let's check MTAP. We're checking a lot more things now, and it requires more tissue.
Sure.
Yeah.
For sure. Let's go back a little bit today to the XD and talk about biomarkers. Because right now for us in breast, there is no biomarkers to use a TROP2 directed ADCs.
Yeah.
There is truly none. But if you look at data from the first TROP2 ADC we got, which was sacituzumab govitecan, they did on those studies something called an H-score to measure the expression by IHC of TROP2. And they clearly showed patients who have high H scores tend to derive much more benefits than the patient with low H scores. Now, the problem with H score is that in breast, we're scared from that because it's not standardized.
Yep.
So what an H score can show in my lab at MD Anderson can be different from across the street at Baylor.
Yeah.
Right. So it's not standardized. So you cannot standardize it. And this is something we went through when we did the estrogen receptors. Estrogen receptors, when they were first documented in the 70s, late 70s, early 80s, to measure them, they used to use the H-score method, and it was awful because nobody could declare what's high, what's low. Everybody had different, and basically the type of stain you use, how long that stain lasts, how old is your even stain. You couldn't do it. So that's why H-score is not making headways. So we're using it for everybody. So we're hoping that in the future there are going to be biomarkers to help us know which are the patients who truly are going to derive benefit from those drugs and who are not going to derive benefit. Now, for you guys right now, I hear from you it's for EGFR positive, but is there something else that you are looking for?
Yeah, so there actually is. We're trying to open the gateway actually to introduce this ADC, Dato-DXd, to patients even without EGFR disease, and we're trying to understand the biomarker. You're exactly right. So they're thinking about using AI, right? Can we use an AI emerged biomarker to help? AI is in everything, right? So now it's also in helping us understand biomarkers and how to treat patients with lung cancer. And so, we're looking to see actually based on a specific AI biomarker or a specific level, might Dato-DXd be more beneficial for patients? And so more to come on that.
It's fascinating how AI is going into every single field.
Yep.
Right now we have the AI that help us write our note in clinic, which has been fascinating.
AI Scribe has been great.
Yes, it really learned the way that you write your notes, and it accommodates. I'll be like, this is the best thing ever.
Yeah.
The AI Scribe, this is fascinating. All right, there is one more thing we want to discuss is, where do you see the future of ADCs in thoracic oncology?
Oh, this is a loaded question.
Yeah.
Yep. That can only be addressed by a targeted missile, right? Okay. I would say, we want to better understand the biomarkers, right? For who can we truly derive the most benefit from these drugs? I think combination strategies, ADCs plus targeted therapies, ADCs plus other drug classes is going to be really important and meaningful, right? And I think continuing to refine how we're delivering these drugs, reducing the toxicity, making these drugs more tolerable, keeping patients to preserve their quality of life. I think that's my wish list, if you will, with ADCs.
No, I agree. For us in breast oncology, this is the era of ADCs.
Yeah.
Truly. It's defining the era of breast oncology. And ADCs right now, as in all cancers, you start from the cases that are the most advanced and then you try to move them. upstream. So right now they're definitely moving to the first line in the metastatic setting, but also moving to the earlier stages.
Wow.
To prevent cancer coming back in the first place and becoming metastatic. So it's really exciting, and it's really defining our era. That's why we're so excited about having them, and it's always good to have options. And then what I'm excited about in the future, the combinations of ADCs, right? So different ADCs target different surface targets, but also they have different payloads.
Yeah.
And those different payloads sometimes can be synergistics, like giving combination chemotherapies. So I'm really excited about those using combination ADCs, but also they're doing those a single target with different payloads attached to that target.
Wow.
So those are also very exciting for us, and they're coming for the breast oncology field. Is there something similar coming to the lung field?
Yeah, I mean, I think trying to figure out these novel payloads, right? It's all about being able to find the target and then deliver that really cytotoxic, dramatic payload directly into the cancer cells, maybe even get that bystander effect. And so, yeah, I think refining our payloads and seeing the progress in that is going to be huge.
Yeah. One of the big things we have right now in breast, the biggest debate is sequential ADC use.
Oh, wow.
Can you use Dato-DXd after T-DXd?
Yeah.
Can you use T-DXd after Dato-DXd and so forth? Is that something similar that you guys are facing?
Yeah, what I can tell you right now is that, enrolling on clinical trials, there's a lot of clinical trials, so I encourage clinical trial discussions all the time. But if you look at if you can qualify for a clinical trial, if you've already been exposed to one of the already approved ADCs, not so much. There's not a lot of crosstalk like we're doing right now, right? So it may exclude patients, unfortunately, if you've already had an approved standard of care ADC to get onto an ADC trial. But I think it's a question that's worth asking, right? Many of these are topoisomerase 1 payloads, and so you have to think about that. And if you've already been exposed to that, is it going to change the game? Is it not? This is an active area of research that I'm excited about, but we need an answer.
So I'm going to tell you some of the studies we did, because some of the studies already came from multiple different places. I'm so happy we were able to replicate them at MD Anderson. Is that what they found is that the timing play a key issue, because here, whenever you want to use sequential ADCs, you have to ask that question. Is it a payload issue, meaning is the cell getting resistance to the payload?
Right.
Or is it a surface epitope issue where those ADCs are
recognized? Yeah.
So the first study came from UCSF, from Dr. Laura Huppert, which showed that if the response to the first ADC was less than 6 months, using another ADC will work, and you'll get more meaningful response than the first, because that is suggesting it's an epitope issue. It's a surface attachment issue.
Okay.
Whereas if patients respond more than 6 months to the first ADCs, then the issue is more about the payload. And then using sequential ADCs is less likely to work. And she proved that by looking at those top 1 enzymes that confer resistance to topoisomerase 1, you can see them increase exponentially after 6 months.
Wow.
If you look at liquid biopsy looking for them.
Yeah.
That's for me was fascinating.
That's fascinating,
For me as a scientist, it makes sense. Hindsight 2020, it makes perfect
what
sense.
I'm thinking about right now is small cell lung cancer, and what we define as platinum resistant versus platinum sensitive, right? And that's 6 month cutoff. I'm like, okay, this is making sense. So we get it. I get it.
Yeah. So that's one of the explanation we have right now, but we have the confirmatory study called a T-DXd. So this is patients when they qualify for both agents, Dato-DXd and T-DXd, they get randomized, 2 groups of patients. One patient start with T-DXd and upon progression go to Dato-DXd. The other group of patients start with Dato-DXd, then go to T-DXd upon progression.
Wow.
And we're going to see if starting with one is better than the other.
You guys are ahead of us.
So this is very exciting. Well, this has been fascinating.
Likewise.
I loved this episode over here and this program we had, and I think it should be at least biannual. We should do it twice. Let's do crosstalk, learn from each other, and move those 2 fields together.
Absolutely.
Thank you so much for joining me today.
Thanks for having me.
That was amazing. Thank you.
Take care.
Thank you all for listening in, and tune in for more episode at CHN.